So I think it is 8:20, so I think we can broadcast
Okay.
to everybody so that we can allow people to join in, and then we'll have a decent number at 8:30 where we
Okay.
actually begin.
Let me know when you want me to share my screen and start, then we'll. Okay.
Sure, I'll let you know.
Okay.
Hello.
Hi, Dr. Mansi.
Yes, hello. So we have your chairperson, Dr. Gazri, in. So I think
Sure.
we'll give your introduction and then we can begin.
Hi, Sanjay.
Okay. Hi, Sunil. How are you?
Oh, good, good, great, great. Nice to see you and nice to talk to you. Uh,
Absolutely.
well, thank you for, acceding to our request. It's always a pleasure to have you and to listen to you. We already have about 80 participants, but as the meeting goes on, we'll have more.
Sure.
Uh, can I introduce you now?
Yeah, go ahead.
Yeah. Sanjay Singh, Dr. Sanjay Singh is the chairman and professor of the Department of Neurology at Creighton University at Nebraska, at Omaha, Nebraska State. He's the chief of staff at Creighton University Medical Center and the director of the Neurological Institute. Currently, he is the president of the American Indian Neurologists Association, AINA. Uh, Sanjay Singh and I go a long way. I came to know him through my friend, through my brother, who's a senior executive at Microsoft. Well, with this short introduction, I will request Sanjay Singh, who has mentored many neurologists and who's a great teacher, to go ahead with this presentation. The screen and the people all over India are watching you. Please, Sanjay Singh.
Thank you, Dr. Gajre. And I want to thank the fine organization too. I'm going to have to do a screen share. So I'll have Dr. Mansi sort of help me with that to see if I can do that. And so I will do that right now. So hopefully, can you see my screen now?
Yes, we can see your screen.
Okay, so then I will get started without further ado. So I was asked to talk about the recent advances in epilepsy. And so what I'm going to do is, in the short span of time that we do have, is talk about advances in evaluation of epilepsy, and then some recent advances in drug therapy of epilepsy, and then the non-pharmacological treatments of epilepsy. So just talk about that. And the way I'll proceed is that I'll talk a little bit about the basics, because I've been told we have a varied audience from senior neurologists to trainees. So I'm going to try and address the needs of each one of them. So let's start with these WHO numbers, which I rarely use in my presentations here in the United States, but it's important for us to really know. There are about 50 million people, as you know, worldwide, and nearly 80% of these people live in the developing world. The risk of premature death with epilepsy is about 3 times higher than for the general population. All of you have heard about SUDEP, the sudden unexpected death in epilepsy. So it's become a big deal all across the world. And the WHO estimates that 3/4 of the people living with epilepsy in the developing world are not getting the treatment that they need. I would actually say a certain percentage of people in the developed world don't get the treatment appropriately either. So this was an interesting map of the incidence of epilepsy. The darker, the higher the incidence of epilepsy. And so you can see where this leads us to in that. And so the question is, why do we need these advances in epilepsy? And so if you looked at that number of 50 million, at least 30% are resistant to all current treatments that we have. And so that will give you an idea that we have 15 million or more patients in the world that will not respond to any current treatments that we have to offer them. And that is why you need advances in the world of epilepsy. So let's start with the definition of epilepsy as it has changed. It used to be 2 or more unprovoked seizures greater than 24 hours apart. And now you can have a diagnosis of epilepsy with one unprovoked seizure if the probability of a second seizure is at least 60%. So it's like you've had the 2 seizures in the past. So if you've had 1 seizure and you have generalized spike and wave on EEG, you are, even with a single seizure, you have epilepsy. The second thing that should be understood is this new definition of resolved, epilepsy being called resolved. And essentially what it is that you're seizure-free for at least 10 years and seizure-free with no medications for the last 5. And that would qualify as being defined as resolution of epilepsy or epilepsy is resolved. Also, you can have age-dependent epilepsy, and if you grow out of that, you can be labeled as resolved in terms of your epilepsy. All right, so let's move on to advances in the evaluation of epilepsy. And so the 2 basic things that we all know should be done in epilepsy patients is an MRI of the brain and an EEG. And so I'll restrict myself to these 2 modalities. And then during question and answer, if people have questions about other modalities, we can look at that. So let's look at what has changed in the world of MRI. And the most exciting part that has changed, which has just come in the last few months, I will talk about. So one of the commonest finding, or at least in the developed world, the most common finding on an abnormal MRI of an epilepsy patient is this mesial temporal sclerosis. And so for the younger members of the audience, it is important that you know how to look at it, because in the studies that have been done, they have found that if you do a regular MRI and it is read by a neuroradiologist inexperienced in reading epilepsy scans, you can miss this finding in over 60% of the cases. So it's the neurologist that really has to know how to look at this MRI scan by themselves. And so here on the right side, if you can see my pointer, you can see that the temporal lobe itself may be a little atrophic compared to the other side. But you can see the hippocampus, see the normal hippocampus with its layerings and size. The hippocampal will be atrophic, and it may have increased T2 signal over here. And why the increased T2 signal? Because there's gliosis in this hippocampus. And so that is showing up in that way. And also you can see, because of the smaller hippocampus, that the temporal horn of the lateral ventricle will be enlarged. So you'll see this as opposed to the normal side. And then the entire Papez circuit may be affected. You might have a smaller fornix, and the mammillary body may be smaller, but that doesn't happen in the vast majority of cases. So this is a patient of mine, and I just wanted to show you on a regular MRI that we do. I shouldn't say regular, it's an epilepsy protocol MRI. You can see the hippocampus is smaller on this side compared to the other. See the normal layering of the hippocampus on this side. And you can see the temporal horn of the lateral ventricle is much larger than the other side. So this would sort of tell you that this is mesial temporal sclerosis, and that has important bearings into the management of the patient. So it's something to be remembered. And this is a FLAIR image of the same patient. You can see that there's increased T2 signal here as compared to the other side. So you see the increased whiteness on this side because of gliosis. So if this is something that we can garner from an appropriate MRI, we can do some more fancy things that we do at our institution. We can do an extraction of the hippocampus and place the 2 hippocampus, head, body, and tail, on the side, which is called a 3D formatting. And so you can see that this hippocampus is smaller than this. But this is not something that would be available at all MR facilities. We also could do what's called an MR microscopy. So now with, as you are aware, the usual Tesla strength of an MR is 1.5 Tesla or 3 Tesla is what an epilepsy scan should ideally be done on a 3 Tesla scan, because you're looking for more structural detail. But you could go up to 9.4 Tesla. And in that, this is the histology of the hippocampus, as you can see. And this is the MR microscopy, so a 9.4 Tesla magnet MR of the hippocampus. And so you can see it can even give you some degree of histological details. My neuropathology colleagues don't like this slide at all, but that this is clearly there as a possibility in the future. Now coming to what has happened within the last few months. So one of the most exciting things that has happened in the last few months, which I think will have tremendous bearing on neurological therapeutics, not just epilepsy therapeutics, across the world, is the FDA approval of this portable MRI. Just happened about 2 months ago. So this is the machine right here, the portable MRI machine. And so this is now approved for people ages 2 and older as a point of care imaging. So in the United States, the idea is this is bedside MRI that you can get, but it actually gives pretty reasonable images. And so the idea is that it would not only be used in the emergency rooms or in the neuro ICUs or on the floors or in the epilepsy monitoring units, but it can be used even in clinics, in the neurology and neurosurgery clinics, because you can imagine that this 5 feet tall sort of device can be kept in any of those locations, and it's only about 3 feet wide. So, and the machine is not is in production after FDA approval. No one except the beta sites have it right now, but it's slated to cost about $50,000. And you compare that to a 3 Tesla of about $3 million or $3.5 million dollars. That's a huge change in this. The images that are coming out of this, the first images were a little grainy and not very clear on this because it's a micro Tesla sort of magnet that's being used. And how are they able to do this with micro Tesla magnets instead of the large MR scanners? This is because they're combining MR technology with SQUIDs, which is super quantum interference devices, which is what was used in MEG scans also. And so what you're getting here is a combination of technologies allows you to have a small micro Tesla MRI to give you images. It has been already, it's being awaited with great fanfare in the world of stroke. In the National Stroke Conference just a few months back, the beta side at Yale, and I must disclose that Yale is my alma mater where I got trained. So I'm a little biased, but yes, it's they presented their stroke findings, with this particularly in a neuro ICU setting, and it was well received. You can see how the patient actually goes into this portable MR scanner, and you can get instant images of the patient through this process as you're going through this. These are some of the more recent images. So you can see, you can get a T2, T1 diffusion. All of those images are possible, including contrast, post-contrast images come through. So it's clearly a point of care here in our countries where it can be placed in ambulances, in neuro ICUs, and can be just wheeled just like a portable EEG machine, and you can get your MR scans in these places. But it's certainly a low-cost option across the developing world because a $50,000 machine is a very different ballgame as compared to a $3.5 million machine. So it's a big change that will, I think, have a major impact on neurology and epilepsy therapeutics. We're hoping to use this for our MR scans even in the EMU, epilepsy monitoring unit, but more particularly in the neuro ICU, because neuro ICU is where a lot of epilepsy therapeutics are now being focused. There's also, I did want to mention, there's this low field MRI. So it's not a portable MRI, but it's a low field MRI, which is not yet FDA approved. It's out of Canada. It's a 0.5 Tesla, but it requires in its installation only 250 square feet. So it can be put on any floor of the hospital or of the clinic, and patients can get this in a 250 square feet. So in cities that have a shortage of space or limitation to space, this is certainly there. And it can be put right next to the neuro ICUs for repeated imaging. This is the actual machine, the EVRY machine, which is being looked at this point in time. But the thunder has been taken out because of the portable MRI. In terms of MRI, there is also the first, all of you must have heard of artificial intelligence and AI, right? It's the big thing in the world today, apart from COVID. But artificial intelligence the first medical approval for any medical application of AI has happened in neurology. And so this is in our neuroradiology imaging. And so what happens? What is this artificial intelligence? So it picks up the CT images from the CT scanner directly, and you have the AI system algorithm. It actually reformats the images, and it interprets the images and then sends them, the images and the interpretation, to the neurologist. And what used to take a few hours, you can do that now. This whole process takes under 6 minutes to do. So under 6 minutes, you do this. So what happens? It is being particularly used in stroke at this point in time. We have it installed in our 15 hospital system that's affiliated to our university hospital. So if someone has a stroke at an outside facility meaning a city 5 hours from here, in one of our hospitals, I can get these images on my smartphone within 6 minutes. So what does it send to me? It sends me CT, CTA, and CT perfusion, right? And so what am I looking for? I'm looking for these parameters: cerebral blood flow of less than 30, or Tmax of greater than 6 seconds. This is cerebral blood flow less than 30 is the core, and Tmax greater than 6 seconds is the penumbra. So what I look for is this pink image, which is the core, and the green image, which is the penumbra. So you can see there is a lot to save here, and therefore I would have my interventional neurologist go in and actually perform an intervention to save the penumbra. So that's what it's being used for right now. But what we are working on is, can this AI system with the MRs done in our peripheral centers, can it also pick up epileptic lesions like cortical dysplasias over here, or mesial temporal sclerosis, or periventricular heterotopias? Because in a lot of those facilities, you might not have really experienced, trained neuroradiologists to look at all these images. And can it do that? And particularly in a country like India, where you have a limited amount of neurologists and neuroradiologists, this can really help, because it can actually do some of this imagery formatting and interpretation for you. And the results are actually comparable to what the neuroradiologist would read. And this does not make my neuroradiologist happy, but this is the reality in the future, where you would have artificial intelligence reading these things, since it's already started. The last thing in terms of MR that I wanted to touch on was this new MRI technology called sodium MRI. For those of you who are familiar with MRIs in epilepsy and other disorders, our current MRI is based on hydrogen. It's based on that hydrogen proton that's present in water, right? So if we can use hydrogen as the basis of an MRI, can we not use other elements? And so sodium is one of them that is currently being looked at. And so what would be the advantage of a sodium MRI? So the idea is, can it pick up epileptogenic lesions? Since you have a lot of sodium channel drugs, sodium channel seems to be involved in the etiopathogenesis of epilepsy. Can this sodium MRI tell us about where the abnormality may lie in terms of epilepsy? And so this is a busy slide, but what I want you to do is look down here where my pointer is. And so there is a developmental abnormality here on a regular MRI. And on this sodium MRI, you can see that that abnormality certainly looks much clearer on the sodium MRI. So it's about how sodium, the relative sodium concentrations in different parts of the brain, and can abnormalities be picked up by the sodium MRI. So you will hear a lot more about this as we go forward in terms of sodium MRIs and even MRIs of other elements. It also has utility in multiple sclerosis. This is a T2 lesion on an MS patient, and you can actually pick that up also on a sodium MRI. So this is something that will have widespread applicability. And why just sodium? You can look at other elements and base your MR pictures on those. So something brand new and fresh to actually think about as we go forward. Now, what about the advances in EEG? Now, the EEG, the one big change that has happened in the world of EEG is ICU video EEG, and I'm sure all of you are involved in that. So, I'm always asked, why ICU? Why should we do ICU video EEG monitoring? And let me tell you, I belong to an era where we never did ICU video EEG monitoring. But then the data started coming out that in patients following convulsive status epilepticus, 48% of patients were seen to have non-convulsive seizures on ICU video EEG. In aneurysmal subarachnoid hemorrhage, we found that in prolonged ICU video EEG, about 10 to 19% of those patients were found to have seizures, and 3 to 13% were found to be in non-convulsive status epilepticus. So as you can see, the numbers in adults and in children, this is significant, including in CNS infections. You can see in acute ischemic stroke. In fact, the recommendation with hemorrhages now, intraparenchymal hemorrhages, is the standard of care involves ICU video EEG monitoring. So it's certainly in hypoxic ischemic encephalopathy, it has a big role. Even in sepsis related associated encephalopathy, you can see that they're finding non-convulsive seizures and non-convulsive status epilepticus in large numbers. So it has become a pretty standard practice now to do this. As you might imagine, this requires a lot of resources because at our center where we do this regularly, someone has to look at this EEG continuously or at least periodically every hour, and that entails day and night as we are going through these processes. So there has been a new advance which has two attractive entities. One, it's a brain stethoscope, the first time that something like this has been invented. And so, for neurologists, it's not a terribly new thing because in EMG, we have been used to, when you do the needle exam, you're listening to not just the waves, but also the audio that used to come out of the classic EEG machines through this. So this is a headband, and let me just show you how it's done. So it's a headband which any nurse can put up, in an ICU, neuro ICU patient or ICU patient. It has 10 electrodes and 8 channels, and then it is connected to this device right here. And so there are 2 parts to the device. One, as soon as she puts that up and turns it on, you can see the live EEG. You can see it on your smartphone from your home. You can see it on a laptop if you want to be more careful about it. But it is, you can do that. The second part is that you can hear the sound from these EEGs. And let me tell you, I did not want to use videos because these days I'm doing 2 to 3 talks a week for different countries and different cities. And I find videos don't do well on Zoom. So I'll just tell you that the sound is a low humming sound when there are no seizures. So it's a low humming sound when there are no seizures. And then when there are seizures, you get these periodic whoosh, whoosh, whoosh kind of sounds. And that tells you. Also, the machine actually tells you on the screen that there is continuous seizure detected, right? So it can actually alert you that there is this. What is the importance of this? In all countries, there is a shortage of neurologists. And especially neurologists who are comfortable reading ICU video EEGs. And so this can certainly help do that. And your EEG techs don't have to come in the middle of the night every time to hook up every single patient unless something abnormal is detected. And so the sensitivity and specificity for seizures is pretty high in this. It's FDA approved, and so it's very good sensitivity and specificity for seizures. It's not as good for epileptic discharges, but when you're doing neurocritical care monitoring in the ICU, you're not really interested in a spike or a sharp. You're really interested in seizures or no seizures, and so this really helps with that. And so this concept of a brain stethoscope, I'm sure this will spread across the world since it just got FDA approval in the last couple of months. This will be widely applicable and it'll be used widely. So you should know about it because hopefully it's coming to a hospital near you soon. Now, what about advances in drug treatment of epilepsy? So as you know, we really had like 5 medications, 5 or 6 medications till the 90s, mid 90s almost. And then there was this huge push in the new discovery of medications. And part of that reason was that there have been a series of animal models that had been developed in epilepsy. And you could put through any compound and you would figure out if that compound is useful for epilepsy or not. So topiramate was never intended to be used for epilepsy. It was developed as an oral hypoglycemic agent for diabetes. They found it didn't do anything to the blood sugar. And so you put it through these epilepsy models, and they found it was an anti-epileptic. Similarly, lamotrigine was never intended as an anti-epileptic. It was developed as an anti-cancer agent. And then it had no anti-cancer properties. It was put through these series of animal models and was found to be an anti-epileptic medication. So we've been lucky and fortunate that we have been developing newer anti-epileptic agents in the last few years too. All of these anti-epileptics have different mechanisms of action. And so, essentially for the younger members of the audience in epilepsy, you either have hyperexcitation of the brain or decreased inhibition of the brain. So for anti-epileptics, either they have to decrease excitation or increased inhibition. So like this GABA receptor is, when this gets activated, it increases inhibition, right? Or the voltage gated sodium channel is for decreasing excitation. And then you have like this SV2A, which is with levetiracetam and brivaracetam. It actually acts on the vesicle, so it doesn't allow the neurotransmitter release. So essentially, those are the two mechanisms, excitation and inhibition. So either you do inhibition or you do decreased excitation, and that's how these anti-epileptics work. Lots of new anti-epileptics approved for monotherapy. This is more of a US kind of slide rather than for the rest of the world, because things are being used. Felbutol, which was one of the first new anti-epileptic, all of those who've practiced since the late 90s remember, came out. It was a good drug, but then it caused aplastic anemia and hepatotoxicity. And so at least in the United States, we had to recall all the patients and take them off the felbamate. I still have about 50 patients in my practice who are on felbamate, but you can kind of do that. The newer medications, the basic advantage is that they have lesser side effects. And so that is certainly the deal there. Pregnancy and teratogenicity, that's a big deal. And so people should be aware of that. And a lot of good work has been done in India too at Sri Chitra. And so, valproate is certainly the drug that everyone has to watch out for, because it can cause about 10% risk of significant fetal malformation. The more recent one is topiramate with cleft palate and cleft lip abnormalities. And so that's been should be looked at carefully. The real issue is that I found this very interesting. This is William Gowers in 1881, right? He wrote an article on epilepsy, and in that he says that he could not control 36% of seizures in whom he prescribed bromide, right? So the real trouble that he had was in 36% of patients. And then the more recent Quantum Brody study or Alan Hauser say the same thing, that we cannot control epilepsy in about 1/3 of the cases, right? And so the question is, have we moved at all, despite all this discovery of new drugs in management of epilepsy, or have we not moved at all? And so one of the things which I have personally worked on is we have to dispel a few myths that are going on. If you look at all the trials of new anti-epileptic medications, they're all done in partial seizures, because the majority of seizures are partial. And so the results that have come out is that they all are about similar efficacy in partial epilepsy, all kinds of partial epilepsy. About between 40 to 50% is what you'll find the responder rates to be. The responder rate is decreasing seizures by 50%. So if you look at all the studies, that's the range that you'll find most of these studies are in. So what is this telling us? They all work about the same. So what this is telling us, all of these drugs have different mechanisms of action. They act on different pathologies, right? MTS, cortical dysplasias, ventricular nodular heterotopias, but they all work about the same. So it makes no scientific sense that drugs with different mechanisms of action that act on different pathologies, and they all come out about the same, right? That does not make any sense at all. And so what I and my colleagues have been working on is we need to find the unique efficacy profile of anti-epileptic medications that will help the clinician in their clinic once they make a diagnosis. Because each one of you, when you see a patient of epilepsy, you take a history and you make a diagnosis of whether you think it's temporal lobe epilepsy or it's frontal lobe epilepsy or parietal lobe epilepsy, but it doesn't help you choose a medication. So what we have done is, this journey started with me a long time ago. So when levetiracetam first came out, this was when I was at Yale, me and my colleagues sort of looked at and were kind of pleasantly surprised by the efficacy of it in temporal lobe epilepsy surgery failure. So those who had failed temporal lobe epilepsy surgery, we had started them on levetiracetam as we were going to work them up for reoperation at Yale. We found that the seizure freedom rate was about 47.6. So these were epilepsy surgery failures, temporal lobe epilepsy surgery failures. And the seizure freedom rate was about 47%. So that was a pretty good number. So it sort of got us excited. And then when I left Yale and came to the Midwest, I sort of wanted to continue down this line. So we looked at single center studies where we looked at efficacy of levetiracetam in garden variety temporal lobe epilepsy, not just epilepsy surgery failures, but garden variety epilepsy surgery. And so we found that in garden variety temporal lobe epilepsy, these were confirmed by imaging, EEG, clinical picture, and plus minus video EEG if we needed to. So we found that the responder rate, that means decreasing seizures by half, was about 80% or so. And the seizure freedom rate was 51.6% in garden variety temporal lobe epilepsy. And so this was much higher than the pivotal trials that were done in levetiracetam, because they included all kinds of partial seizures. So we were interested in this. Then we wanted to see, what about temporal lobe epilepsy with mesial temporal sclerosis? What about that subgroup? So we looked at that, and that had a similar seizure freedom rate. So clearly, we, in our limited, single center studies, we found that there would be unique efficacy profiles of these anti-epileptic drugs that we would use. So we at our center will not take anyone for temporal lobe epilepsy surgery unless we have tried levetiracetam in these patients. And I think epilepsy centers around the world have an opportunity to find unique efficacy profiles of these medications. The pharmaceutical industry has no incentive to do this. Why would they limit themselves to a particular kind of partial seizures? It's up to us as epilepsy centers to do this and neurologists to do this kind of studies. Now, what about the newer drugs and indications for that? So one of the new drugs that I was just told is not yet available in India is Cenobamate. You will be getting it pretty shortly. It's actually through a South Korean company. It's indicated now, FDA approved, for partial onset of focal seizures in adult patients, not pediatrics yet. And how does it work? So it has two mechanisms of action. Once it increases inhibition through modulating the GABA-A channels. And number two, it decreases excitation by inhibiting the sodium currents through the voltage-gated sodium channels. So it has two major mechanisms of action, as you can see. It has a half-life of about 50 to 60 hours. So it is given once a day. So it'll be once a day medication, which is good for compliance. It's primarily eliminated in urine. The one drug-drug interaction that people should be aware of is it potentially can raise your phenytoin levels by 200% because it inhibits this CYP2C19. So essentially, that is one interaction that one must remember. So if you are introducing cenobamate in a patient on phenytoin, as you build up cenobamate, you'll have to cut the phenytoin by half. So that's something to really remember. Two large trials, typical epilepsy, partial epilepsy trials. So you have a maintenance phase, you have a titration phase in which you have placebo and then 3 doses of the drug, 100, 200, and 400 milligrams a day. And then you look at the results. And the median percentage change in seizure frequency. So this is kind of an interesting measure, but this is what everyone has to do because the US FDA mandates it at this point in time. And so what was interesting was, as we have been seeing recently, there was decrease of 27% in the placebo group. Many reasons could be there for this high placebo response in a lot of medication trials. probably one of the major ones is that the medications that they are already on, they start taking them regularly because there's a nurse checking on them for that. But you can see with 100 milligrams, the decrease was 41.5, 200 milligrams, it was 56.5, and 400 milligrams was 63. So those were the results in terms of median percentage change. Now, what about for seizure freedom? Seizure freedom at Cenobamate of 100 milligrams was 4%, 200 was 11%, and 400 was 21%. So these are people who have failed medications and are now starting on these particular drugs. The dosing of Cenobamate is going to be similar to how we have used lamotrigine in the past. So you started off at 12.5 milligram, and then you double it every 2 weeks till you get to 200, or you can further increase it to 400. These are the two dosages that have been approved for use in Cenobamate. Now, I can tell you what I tell my residents and fellows all the time, that my dictum for use of any anti-epileptic drug is start low and go slow, right? And you will never go wrong. So no matter what is recommended, please follow the dictum of start low and go slow. Side effects, somnolence, and, if it acts on remember it acts on the GABA and the sodium. And so the GABA would certainly cause somnolence and fatigue, right? And the sodium channels can cause dizziness and diplopia. So it sort of is explained by that, but these are the side effects that were greater than 10% in these pivotal trials, and headache was there. And then I do want to tell you that there was the DRESS, with eosinophilia and systemic symptoms in 3 out of 953 patients. So this was certainly something that we have to watch out for and be careful about in this drug. Contraindication, obviously hypersensitivity, but more importantly, that if someone had a familial short QT syndrome, they should not be on Cenobamate because it's sodium channel action, it has the potential of shortening your QT interval. So that is something to be remembered. It has generated some interest, this particular new anti-epileptic drug. This is the Epilepsy Current with David Wassler. He's particularly marked out the 63% reduction at maximum dose, which is pretty significant. And so we are hopeful that this will be replicated. We have to still see whether this will be actually replicated in clinical scenarios that when you and I treat the patients, but it's something to watch out for. Intranasal Midazolam, it has been approved in the US within the last year or so. And so, it might have been approved even earlier in India, but I'm not aware of that. So it's clearly intranasal midazolam is replacing the rectal diastat, diazepam that we used to use rectal, because you had to put in suppositories and patients' families were not very comfortable doing that. And so intranasal midazolam replaces that. It's important to know how to use it. It's a 5 milligram spray in one nostril, and you can repeat it in 10 minutes once. And you should use this once in 3 days and not more than 5 times in a month. And so that's something to be there to look out for. It should not be used in acute narrow angle glaucoma. And so that is something important to kind of look at. The important thing is here, between 10 minutes and 6 hours after its use, initial dose, 58.2% did not experience another seizure as compared to 37% in the placebo group. So that's what it is. Side effects, somnolence, obviously with midazolam, but headache, nasal discomfort, throat irritation, and rhinorrhea. And so those are some of the things to kind of keep in mind as you're proceeding with this. Now, in this country, we've had Cannabidiol, one of the cannabis marijuana-based product that has been approved. The first and only approval is in epilepsy. And so there is humongous interest in this country. I've been told that this is not available in India so far, but I'm sure it'll be there with Greenwich pretty soon. So FDA to approve cannabis-based seizure drug. This has gotten more TV time than all of epilepsy put together in the United States. So this is Epidiolex is the medication. As it comes, it's an oral solution. Now remember, in cannabis, in marijuana, there is CBD, that is cannabidiol, but there's also THC. THC is the part that was responsible for hallucinations. CBD is more of an inhibiting compound. And so what they've what has to be done is THC has to be taken out and cannabidiol has to be used by itself. It is now approved by the FDA for treatment of only Lennox, Gastaut, and Dravet. That's all that it is actually approved for. It is not approved for partial seizures, not approved for generalized seizures. It's approved for Lennox, Gastaut, and Dravet. And for the younger members, I just wanted to review Lennox, Gastaut. It's a triad of multiple seizure types, particularly tonic and atonic seizures, slow spike and wave, so less than 2.5 hertz on the EEG, and then mental retardation. So if you have a combination of these three, or at least two, then you're suspecting Lennox-Gastaut in this. This is a typical Lennox-Gastaut EEG. So you look at the normal EEG up here, and you can see the slow spike and wave of a Lennox-Gastaut in the bottom one. Dravet is a very rare syndrome. We have about 10 to 12 patients, but that's because we're a university epilepsy center, and so we get a lot of referrals. But this was previously known as severe myoclonic epilepsy of infancy, and it continues in adult. 75 to 80% have this mutation of this SCN1A gene, which is very important for neurology, because this SCN1A gene has this spectrum from familial hemiplegic migraines to Dravet. And so this is an important thing to sort of keep in mind as you're going through this. We do not know the mechanism of action of cannabidiol. There are cannabinoid receptors in the brain. This drug does not act through any cannabinoid receptors. So that's important to know. So it has, it can affect liver function. So you should obtain a baseline liver function test and then monitor it from there on. Since it's not yet available in India, I'm not going to go into too much dosing, but it starts at about 5 milligrams per kilograms per day in BID, and then you can go up to 20. Adverse reactions, obviously the most common is somnolence, which is understandable, but then decreased appetite, diarrhea, liver function abnormalities, fatigue, rash, insomnia, all of those have been looked at. You have to adjust it if there's hepatic impairment. I would suggest not giving it. This is important. So in clobazam, which is much more frequently used in India than here in the United States, as I understand, clobazam, if you administer cannabidiol, it can increase the clobazam level by threefold, 3 times. So you can get clobazam toxicity when you introduce cannabidiol. And both of these are approved in the United States for Lennox-Gastaut. So this is an important drug interaction that we have to be aware of. In Lennox-Gastaut, this drug has decreased seizures by 41% as compared to 14% of placebo. So that's a big deal. This is just visual of the same. And then in Dravet, it decreased seizures by 39% as compared to only 13% with placebo. So that's that. Let's move on briefly on this status epilepticus protocol. This is our institution's one, which is one of the classic ones all of you know. Lorazepam, phenytoin, phenobarb, and then instead of phenobarb, you can go directly to the anesthetic agents, which we do now with Versed and propofol, midazolam and propofol. The American Epilepsy Society has come out with some change to this protocol, and I did want to get your attention to it. So instead of just using IV lorazepam, they think intramuscular midazolam, if you don't have an IV line, is okay too. And in places where you don't have any of these, which I would be surprised to see, but they say IV phenobarb can be tried at that point, or even intranasal midazolam can be tried. And then IV phenytoin, but they say you can also use IV valproate or IV levetiracetam. Now remember, there are no randomized studies with this. In fact, the only studies with IV valproate and IV levetiracetam in status epilepticus have come out of India. And so that is something that they do recommend. So now in the United States, it is legitimate to use IV phenytoin or IV valproate or IV levetiracetam for management of status because of these new guidelines that have come out. So before I move on to some of the newer agents that will be becoming available soon, for the younger members, I did want to just briefly touch on this. So there are these 4 phases of human clinical trials, and you're hearing a lot more about it with the COVID, drug trials and the vaccine. So the phase 1 is to assess safety of a drug. So this is for the younger members of the audience. I apologize to the most senior members. The phase 2 is also small studies looking at efficacy, to test the efficacy. Phase 3 is to establish the efficacy. So these are the randomized controlled trials that you all are used to hearing about. And phase 4 is post-approval. These are post-marketing to see if there are new indications for the same drug that has been approved for one. So in the anti-epileptic drug pipeline, the four major ones in phase 3 trials are ganaxolone, which is a GABA acting drug, another cannabis-based product that is being looked at, naloxone, which is being looked at for preventing SUDEP, and then fenfluramine, which is modulating serotonin, particularly in Dravet syndrome. But these are some of the ones. I also wanted to just give you a picture of phase 2, the ones that are coming through. I don't expect you to read this, but you can see there are a ton of new drugs that are being looked at as anti-epileptic agents. And so I would suspect on an average in the next 10 years, you're going to get a new drug every year almost. Dietary supplements are being looked at. So there is this beta shot, which is based on the ketogenic diet concept. It's medium chain triglycerides in the food. And it's being studied in phase 3 now for patients between 3 and 75 years of age for epilepsy. And so this may be something that we, depending on the phase 3 results, we might be hearing about it. There's also, I found this interesting, a ginseng extract is being looked at for decreasing spread of epileptic discharges. So it's in preclinical studies right now, but it's a dietary one. Now let's move on finally to the non-pharmacological treatment of epilepsy. So this is non-drug therapies. The first thing it's not really a therapy, but it is important, is this device that you wear on your wrist. The epilepsy patients can wear on their wrists. It's Embrace 2. It's now FDA approved here in the United States. It is available by prescription only, medical prescription only. It's for children ages 6 and up, in adults and elderly. Essentially, it detects seizures. And how does it do that? By motion and by electrodermal activity, EDA. So by that, it detects seizures, and then it will alert the family by smartphones that someone's having a seizure. So one of the big things in seizures is not essentially when the part in the majority of the patients, when they're actually having a seizure. It's not knowing when the seizure is going to happen. And the family is particularly concerned as to whether they'll miss a seizure and the patient may have SUDEP or some other, may hurt themselves. And so this device can help with that. So it's very recently approved here in the United States, and I'm sure it'll be going around the world pretty soon. Epilepsy surgery, all of you are absolutely aware of the temporal lobectomy. That is the most common kind of epilepsy surgery, which has a randomized controlled study. And so, surgical group had a seizure freedom rate of 58%, and the medical group had 8%. So there's a significant difference. So in classical mesial temporal lobe epilepsy, those patients, if they fail medications, they are certainly candidates for surgery and should be referred for the same. The vagal nerve stimulator has been around for a while. The only thing new is now it's a responsive vagal nerve stimulator. So it actually picks up on the heart rate. There's a lead that's checking your heart rate. And based on that, it can send a shock to the brain to avert a seizure. So I understand it's not in widespread use in India yet, vagal nerve stimulator. We had one of the Indian Academy of Neurology and INA joint observership training program observers who came to us for 6 weeks. We trained her in this particular modality to see. The newer thing is the deep brain stimulator. It is being done in other countries, but in the United States, it was not approved yet. And, all of us have a favorite part of the brain that we were stimulating, particularly in the thalamus. So we at our center, some time back, had done stimulation of centromedian thalamic nucleus. And we did 4 patients. These are patients who had failed epilepsy surgery, failed VNS, failed medications. And so 3 out of 4 actually had a greater than 50% reduction in seizures. And one of them who actually had a infection of the stimulator, where the stimulator had to be taken out. This was one of the patients who had benefited. And when the stimulator was taken out, they started having more seizures. So it was kind of an interesting study, which we presented at the American Epilepsy Society. The anterior thalamic stimulation is what is now approved for use. So some of you may remember the trial, the Sante trial. And this is the only setting right here in the bottom line is what it was approved for. And so we are using this now at our sites. But after the Sante trial, which showed a decrease, but it was not significant enough, so the FDA did not approve it. Then they had a long-term follow-up study, and they found that the benefit of the deep brain stimulator continued over years. And that is when the FDA approved it just about 12 to 14 months back. And so that's when it's actually started here in a legitimate way in the United States. We also have the responsive neural stimulator, where you put in electrodes to monitor for seizures. And then when the seizure is detected, this implanted device then shocks that spot and stops the seizure from happening. So that's how the responsive neural stimulator is there. So neurostimulation summary. So this is one of the published data. So after 3 years of implantation in DBS, 51 to 58% decrease in seizure frequency, 48% in RNS, about 44% in VNS. So similar with a little slight edge to DBS. Seizure free is less than 10% in these patients. So now they are continuously improving. And this is one of the things where we are looking at to see with artificial intelligence, can we do anything better? And so we are, in terms of seizure detection, we are at our institute working on an artificial intelligence algorithm with our engineering school of computer sciences. And we've developed an algorithm to actually detect seizures. We've presented and published it more recently. But I just wanted to share with you that artificial intelligence is going to play a bigger and bigger role in fine-tuning stimulation parameters according to the seizures, and also detecting seizures, and at some point, maybe even predicting seizures. Transcranial magnetic stimulation for epilepsy, it has been all over the place. So there have been 3 studies that showed no significant benefit, 4 that have shown significant benefit. So why this mix of findings? Because mix of patients and no standard protocols. So the bottom line is that if you do low frequency transcranial magnetic stimulation to the seizure focus, it's likely that patients will benefit. And more recently, they've come up with a new device, transcranial magnetic stimulation, because the limitation is that you can only do TMS in the surface of the brain. And if the seizure focus is in the depth, what are you going to do? So now they've come up with a device that actually can stimulate your hippocampus, so in the depths of the brain. And then that should be a new avenue of management. And the real advance, in my opinion, and I'm a little biased since we have this, we're doing this particular device. So this is called Exablate. This is focused ultrasound. And so this is where you can non-invasively burn parts of the brain, without making any incision. It's incisionless brain surgery for the first time. It's been approved for essential tremors and Parkinson's tremors. So the idea here is that the patient comes in, walks into the MRI machine. This here is the device, the Exablate device. It delivers focused ultrasound. So you can do this on an MR panel. It's MR guided. And so on an MR panel, you find the spot, you burn it with the thermal energy, and you have thermal maps at the same time. And then the patient has had this, and the patient walks home. So it's an outpatient procedure. It does not even require admission to the hospital. The patient walks in and walks home the same day, right? So this is really the future of neurotherapeutics in this. My neurosurgery colleagues are very concerned about this, because right now neurosurgery is doing this. But let me tell you, I don't see why neurologists cannot do this, because all you're doing is sitting on an MR panel and finding 7 millimeters up and 5 millimeters lateral, and then that's the site, and you give a subtherapeutic dose and you see how the patient's doing. We at our site, we've implemented this about a year back. We are now the busiest site in America doing this. We have patients from all over the country and all over the world that come for essential tremor management. And they get this, and their tremor's gone, and they walk home. So this is now also being looked at for epilepsy in terms of, we are trying to see if we can do this in the anterior thalamic nucleus like DBS. Instead of a DBS, can we burn it and see what the benefit is? Patients look at you when we give them a choice between this and deep brain stimulator for tremors as if you're crazy, because this is an outpatient procedure with no incision, no device or metal put into their body. And so I would think that this really would have a revolutionary role in neurotherapeutics. It's being also looked at for brain tumors to alter the blood-brain barrier to allow chemotherapeutic agents to go in better. So keep your eye out for this technology. You will see a lot of it in times to come. And so what about in the device pipeline? Exablate, obviously, we've talked about. There is also this transcranial direct current stimulation. So it's literally a battery with electrodes, which is stimulating. You also have the more fancy star stim apparatus, but it's direct electrical stimulation of the scalp of the head of the patient. And that is showing some initial promising results in epilepsy. And so you might hear more about it in times to come. So I would end here my presentation, and I'll be happy to take any questions that you might have. Thank you all for listening.
Thank you, Sanjay. It was a fantastic talk. Can you hear me, Sanjay?
Yeah, I can hear you.
Yeah. We had about more than 300 participants, although it's a Sunday evening, and
Yes.
Sunday evenings are usually not meant for academics, but having 300 participants is a great thing. And we really, really enjoyed your lecture. It was something like science fiction, the way you were telling things. Now we can go to some of the questions. There is one question, he hasn't given his name. What is the use of the brain stethoscope in non-convulsive status?
So its primarily use is in ICU video EEG monitoring, where you can't have someone looking at it all the time, or you don't have techs available to go in. So I would think in the United States, we are out of the university hospital, non-university hospitals really are excited about it, because they can use it in all their ICU patients to see if they're in status or non-status. It can also be used for epileptic discharges in places where you don't have 24/7 video EEG facility. But yes, its primary use is in ICU video EEG, which is a huge deal here in the United States. In fact, we are doing a lot more ICU video EEG than regular video EEG in the country now.
Okay, the next question is by Nikhil Repaka. He says, he's asking, is clobazam black box warning for Stevens-Johnson syndrome?
Mm-hmm. So there is the issue of rash is there, but I have to say it's not a very common finding. Some of us were surprised by it, because you don't see that in the other benzodiazepines that often. But it certainly has been reported. So we all watch for it and we educate our patients about it. But I have probably 200 plus patients on clobazam, and I have not seen one. But we do give that warning out. That's the exact utility of it.
Because we very rarely have seen it. I have not seen it up till now. Of course, I'm a general neurologist, but
Yeah.
it's very rare as compared to phenytoin or carbamazepine.
See, what happens here in the US is when a clinical trial is ongoing, and just so that our audience understands this, if something happens, it has to be reported and has to be in the drug insert. So if you do your studies during the period of the winter months, right, almost one side effect is going to be common cold, right, because it occurred in those patients, and so it has to be reported. So this is the FDA mandate. So similarly for this rash, because it occurred in a small number of patients, it has to be reported, and therefore the warning is there.
Pramod Dhonde has asked, one app sees alarm on iWatch or emergency SOS on iWatch. Is it helpful in an emergency?
So we cannot use anything that is not FDA approved here in the United States. So my experience is only with FDA approved devices, and the only one that is approved is this Embrace 2. And so because they have to go through rigorous tests, and that's when this can be utilized. So in our settings in the United States, we cannot recommend anything that is not FDA approved. And so our experiences with Embrace. But if someone does have that kind of an experience, you should write that up, because it'd be useful for us to see what the medical studies have shown. But I'm not aware of a lot of robust randomized controlled trials on them.
The next is a compliment, or there are many compliments. Awesome, sir. What's your take on lattice model of nodes and edges and long-term outcome of post-surgical patients?
So the question about networking and network, one of my mentors, Susan Spencer, under whom I trained, she was the founder of this networking theory in epilepsy. And now, we do stereo EEG, which is based on this networking and nodes and lattice kind of concepts. It's certainly there. I still have to see whether you can have, whether you show that stereo EEG is definitely better than routine intracranial monitorings of depth and subdurals. So that is an area that the question hasn't been finally answered. It's still very useful and should be pursued. Yeah.
The next question is by Padsala, K.I. Padsala. What is the cost of exaplate neuro?
So exaplate neuro is, in this country, would be about, I would think it'd be about around 2 million or so, but it should be different in different countries. So it's certainly something that we are excited about. And, we are the busiest site in the United States and in America right now, and the second busiest in the world, as they tell us. So, it's something I think is the future of neural therapeutics, because if you can do an outpatient procedure and send the patient home the same day in 3 hours, it literally takes 3 hours to do this. It's a major advance. And I would say at some point, non-surgeons would actually start to do this because there's nothing real surgical about it.
So we would be taking away work from our neurosurgical colleagues. And that is a good thing, because
you're going to get me into trouble.
Right. And I think they would deserve it. What is the role of AI in EEG interpretation?
So we have we have developed an algorithm, me and my colleagues from the School of Engineering have worked on developing this AI system on picking up seizures. So the AI is picking up seizures with great, accuracy in doing this. And so if it can do that, I don't see that it would replace the EEG reader, but it would help you as an EEG reader. It would sort of, when you were only able to care for 2 or 3, continuous EEGs, you might be able to take care of 6 or 7 because you have an accurate AI system that will detect these seizures and let you know. It will also help the emergency rooms where, you could have a device where the AI picks up a seizure and then they know whether the person is having a seizure or not having a seizure. And then that will make your life easy instead of you having to send in your EEG tech to do that. So the AI will have a major role. I think in neuroradiology, it will have a tremendous role. It might replace a lot of neuroradiology. It might also replace a lot of neuropathology because in the CT of the chest for pulmonary nodules and cancer, its accuracy is even greater than radiologist at this point in time, some of the studies. So, I think it'll have a major impact as we go forward.
Many times it happens that the radiologist fails to give all the differential diagnosis, while AI would never. Artificial intelligence would always give everything. So that is one place where it may beat the radiologist. Well, yeah. I hope there are no radiologists on this broadcast. Another question is, what is the particular place of brivaracetam in the management of epilepsy? We have levetiracetam and also brivaracetam. It's costly, more costly than levetiracetam. So it's not being used much, but somebody has asked that.
Yeah, so brivaracetam is indicated for treatment of, partial or focal onset epilepsy. It cannot be given to patients who are on levetiracetam. So that's a contraindication of that. So you're right. It has not been used with in large numbers. But if you have a patient, you could use it as an add-on therapy for partial seizures in case they've failed other medications. But that's the only role.
At this point, I have seen some people add oxcarbamazepine to somebody who's already on carbamazepine. and they say that it has worked. So would this levetiracetam plus breviracetam work in any way? I have no experience. But
So good point that you made, because in oxcarbazepine, if you remember the studies, almost 50% of people who responded to oxcarbazepine in the pivotal trials were those that had failed carbamazepine, because in those days there were very few antiepileptics. So there was good rationale to do this. In brivaracetam, if someone has failed levetiracetam, you can then try brivaracetam, but you cannot start the two medications or use the two medications together. That's what's contraindicated.
Right. Krishnamurthy has again asked about the experience with breviracetam. How many patients have you put on it, and what is your take on it?
I have probably 100+ patients that are on brivaracetam. It shows what we see in clinical trials. In about 40% or so, it has worked. In the others, it has not. I have, in my personal, and let me preface this by saying this is not a randomized study, but in my patient population, I have not seen a decreased behavioral side effects as it was, advertised as compared to levetiracetam. But it does have efficacy in patients, similar to what the clinical trials have shown.
Is it anyway better than levetiracetam?
No, there is no such evidence at all.
Right.
The number one drug used in the United States today is levetiracetam.
Oh, it is.
Yeah.
Ravikant has asked, is lacosamide better than levetiracetam in temporal lobe epilepsy?
So no one has done that study with lacosamide, and part of my motive of showing you or sharing our studies with you is that these are studies that can be done in any center, even in a private practice setting, because it's just about keeping record of who you started and how they've responded. And so levetiracetam at this point is the number one drug for temporal lobe based on the studies. And a lot of centers, actually would tell you that they've seen that kind of effect. And so these are things that I think need to be studied. There's no study about lacosamide and temporal lobe epilepsy, that shows any efficacy. But these things can be done. Like one of the studies we have done is with levetiracetam, when you have behavioral side effects, we have added vitamin B6, 100 milligrams once a day. And that has taken away the behavioral side effects of levetiracetam in a significant number of patients. We presented that at the American Academy of Neurology meetings. We don't know why. We don't know exactly what cofactor would do this, but it is now being seen by people across the United States that you can use vitamin B6 to take the edge off the behavioral side effects of levetiracetam.
Oh, that's a great point. We didn't know this, and probably neurologists in India would also be doing that, because the parents do complain of a lot of side effects, especially behavioral ones with levetiracetam. Somarajan has asked, temporal versus extratemporal epilepsy, which drug would you prefer?
Yeah. So temporal lobe, obviously, I'd prefer levetiracetam. For extratemporal, there are very few studies. So one study that has been done is in frontal lobe epilepsy, and it was a limited study, but it showed that if you used a combination of valproate and lamotrigine, it showed some good efficacy in frontal lobe epilepsy. Now, remember, this is still an anecdotal study, but that's the kind of data that we have. We really don't have good data on extratemporal lobe epilepsy and different drugs. So that study will never be done by pharmaceutical industries. That has to be done by epilepsy centers or neurologists themselves, where we have to find these unique efficacy profiles. But that's the only data that exists right now.
Yes, these unique efficacy data is something which we really have to work on. If Naveen, I don't know his full name, he has asked if seizures don't stop with the first dose of intranasal midazolam, can a second dose be given?
Yes, a second dose can be given after 10 minutes is what the recommendation is. You can give a second dose of a 5 milligram in the other nostril, but then after that, you cannot do anything further.
And is intranasal midazolam contraindicated in children below 12 years? I don't think so. I mean,
it's not contraindicated, but in the United States, again, the study was done in that age range, and that's why the FDA gave it an indication in that age range. So once they do a study in the pediatric age range, then they'll get that. And I'm sure UCB will try and do that.
The person has asked that Amongst the anti-epileptics, levetiracetam seems to be a weak anti-epileptic and lots of behavioral issues as compared to, say, valproate. What is your take on that?
So levetiracetam in the United States is by far the number one anti-epileptic being used primarily because of efficacy. So, so I would suggest that it has pretty good efficacy, especially in temporal lobe epilepsy and partial epilepsies. And also in juvenile myoclonic epilepsies, levetiracetam will have good efficacy. Valproate has a role of its own. The problem with valproate has been, obviously, you have to do blood tests for liver functions and drug levels. The other thing is that in young women, childbearing age range, it's contraindicated now in the United States. They've come out with a thing that it should not be used in childbearing age range because it not only has fetal malformation by itself, it is about 9–10%. It can also cause low IQ in children and mothers that have taken valproate. So because of these multiple effects, its use in women is certainly limited. But it is a good anti-epileptic medication. Valproate also has a very interesting story. When they were trying to use it, it turned out that it was the solvent in which the valproate was present that was working. It wasn't any of the drug trials that were done on valproate. So it's a good drug, but it has its side effects, just like all do. And so it should be, both of these drugs should be used in their appropriate settings.
And one more question, an anonymous attendee. What is your take for interictal PET versus interictal SPECT versus ictal SPECT in the diagnosis of epilepsy? Which one is better and why?
So interictal PET scan is certainly something we do all the time. It is particularly useful in temporal lobe epilepsies, and it does well. Ictal SPECT, we have done ictal SPECTs, but logistically it is a nightmare to do an ictal SPECT. Someone has to be sitting in the patient's room or close by with a syringe full of this radioactive material to inject into the patient. And the problem is, if you drop even a little bit of it on the floor, then that room has to be sealed off and till the half-life has gone and all. So in ictal SPECT, was much more of a rage in the from 2000 to 2010. Now that you have a lot of other ways of working, it works there. But if you can use it, especially if you can do a SysCom, subtraction ictal SPECT from interictal SPECT, the idea is it is a very good modality. Interictal SPECT, I think, a PET scan is utilized in temporal lobe epilepsies and extratemporal too. But the utility is just correlating it with the other modalities. So if you can do an ictal SPECT, I think it's a great way of defining the seizure focus. But just doing it and using the SysCom technology has to be available to do it.
Yes. Krishnamurthy has again asked, in a young female in a reproductive group, she develops a skin rash with levetiracetam. What would be your next choice? Well, levetiracetam as such gives very few reactions, but what would you do in this rare situation?
So it depends upon the kind of epilepsy. I forget whether he has mentioned the kind of epilepsy.
Clinic, I suppose.
Okay. Yeah, I mean, so I would go to another. I would not, if it's rash and we established that it's from the levetiracetam, then I would use another anti-epileptic medication. If it's primary generalized epilepsies, your options would be lamotrigine, topiramate, and those kinds. If it is, partial seizures, then all the drugs are options for you at that.
Nilesh Kinge, who's a colleague in Jalgaon, has asked, what is the image quality of a portal MRI? Is it like...
It's not as good as a 3 Tesla magnet MRI. Certainly it's not that, but it is certainly interpretable. So if you were looking for subtle, changes, like, gray-white matter, junctions and stuff, it's probably not as good right now. Now, they are further improving it by using AI, artificial intelligence, because artificial intelligence does not only look at the picture, it looks at pixel by pixel and the pixel strengths. And so that would probably increase the yield, but the picture is certainly not. And in the United States, it is not slated to replace conventional imaging. It is slated to be the point of service. So, you can use it in a neuro ICU without moving the patient. You can use it in the emergency room. You can use it in a neurology, neurosurgery clinic to get you those initial impressions. Plus, a machine of this sort, I think it's better than no machine at all, and it will really improve the care for inpatient and emergent neurology.
Yeah, not only it would improve the inpatient care, but in India, you could load it on a truck and you could move it at smaller places once a week, and a lot of patients would benefit from it. That is another thing which I see in the future.
Absolutely.
Do you have time? Because we have 3-4 more questions.
Yeah. Please go ahead.
Dr. MRK, he is not given his full name. Any extra advantage of eslicarbamazepine over carbamazepine or oxcarbamazepine?
No, there's no. There have been no studies to show head-to-head comparison between these three to see one is better than the other. But yes, I have seen that patients who have failed carbamazepine or oxcarbamazepine have benefited from eslicarbazepine. That I have seen. But the rider is you should not use eslicarbazepine and oxcarbazepine together. That is not something that's recommended.
Also, once a day dosage of eslicarbamazepine, that's what they claim.
Yeah, the compliance would certainly be better.
Yeah. Datta Nadgir has asked, where do you place zonisamide, the Japanese drug zonisamide, which we are using in India to a reasonable extent in epilepsy? Do you use it in the United States as well?
Yeah, we do use it. We do use it. It's one of the drugs that is there for partial onset seizures that we have been using. It's not very commonly used in the United States. I probably have about 75, 80 patients on it. And it's just, it does have that carbonic anhydrase sort of property. So like topiramate. And so one has to be careful of the side effects, but otherwise it should be used. Here, I would like to mention, I don't know if they use tiagabine in India that much, but if you do, one of the side effects that we are now noticing is that sometimes it can put a patient in spike wave stupor. So if you start someone on tiagabine and they have mental status changes, please think about spike wave stupor that can come out of tiagabine.
Tiagabine was available in India once upon a time. Sun Pharma used to make it, but somehow or the other it didn't pick up, and we don't get it nowadays.
Okay.
What's your experience of perampanel in focal seizures? We don't use it much in India, but it's available.
Yeah. So perampanel is one of the new drugs. It has a unique mechanism of action with the AMPA. So do we use it? Yes. One of the problems is its side effect profile. So in the side effect profile, as you know, one of the side effects is that it can cause homicidal tendencies, and that's in a warning. Right? So when we explain it to a patient or the family that it can lead to homicidal tendencies, where he can start to murder people or may think about murdering people, a lot of people don't want to go on it. But otherwise, it's a pretty unique drug, and it has a broad spectrum, applicability. And so, its dosing is pretty appropriate. So it can certainly. Do I use it? Yes, I do use it, but I do see some resistance amongst the patients to these kinds of.
And what is Datta Nadgir is again asked, what is the best combination of anti-epileptics in LGS with drop attacks? Lennox.
Yeah. So Lennox Gastaut with drop attacks, or Lennox Gastaut, because in most of the studies, they've only looked at drop attacks as a measure. So, the drugs approved for it are lamotrigine, topiramate, and then obviously the new ones like clobazam, which is new for us. Not for you all, but clobazam and then, cannabidiol. And rufinamide, is also approved for it. So what I generally do is I use one of the classical medications like lamotrigine or topiramate, try those, and then probably add a clobazam to that and see if the patients respond to it. If they don't, then other medications may become an option.
And Vikram Kamath has asked, is there any role of perampanel in status epilepticus?
None right now. So we really have not used it. If someone has used it, I would request them to publish, because we would like to know what their findings are, but none at this point in time. And it's not indicated or approved for clinical use and status in the United States right now.
Surendra Kumar, who's from RIMS Ranchi, has asked, what is the role of the ketogenic diet in atonic seizures?
So ketogenic diet is certainly used in Lennox Gastaut in children. Johns Hopkins came up with this sort of thing. We have two researchers who are actually working on mechanism of action of ketogenic diet at our center. But the ketogenic diet can only be used in children, and it is not an easy diet to keep a patient on with no carbs and a lot of fat. Its utility is there, but it's only in the pediatric population. And as I showed you, some of the new dietary supplements that are based on a ketogenic diet concept, that is being studied in clinical trials. So we'll see what that comes out to be. My hunch is that we will have to figure out what inside the ketogenic diet is actually causing the benefit. Is it a particular molecule, or is it a particular molecule that is avoided? And then once we find out exactly the mechanism of action, then it may have more widespread utility. But right now it's pretty limited to younger children.
Probably it's the acidosis, the metabolic acidosis that the diet causes. That is the one which suppresses the seizures. That is one of the mechanisms postulated. It may be a constituent. Well, I have a few patients on ketogenic diet, which they most often don't like to follow. Well, we go to the last question now. How many patients do you have on cannabidiol?
So I have about 11 patients or so on that drug. It's as you might imagine, you can't keep samples of this drug in your clinic because you'd have to have the biggest safe and a policeman watching over it. I think it's a journey that we are on right now. And at a university epilepsy center, we do have enough Dravet and Lennox Gastaut to have some patients on it. For the general neurologist, unless the indications, sort of become more wide and include partial seizures, it's going to be interesting to see how it's utilized. But yeah, there is a lot of excitement. I have many patients who come and ask me about it. And I'm sure when it gets introduced in India, you'll be asked a lot about this cannabis, marijuana-based compound. In fact, the plant that it comes from, as far as I know, is Cannabis indica. So it's something that I'm surprised is not available yet in India.
Yeah, it's not available yet in India. Well, one comment that the low field MRIs, they would be very useful in cities like Mumbai and other places where prices of place or where the clinics are in a very small place. There they would be very useful. And right next door, if you have an MRI, it's very useful. And in India, what we tend to do in status is that if the patient has status and has fever, then after lorazepam, we usually prefer IV valproate, because for fever-induced seizures, it looks to be the better drug instead of phenytoin. Many centers are doing that, but we don't have any trial, but it looks sensible to do that.
Yeah, I would suggest that, I think that would be very useful if it's written up, and all of us would benefit from it too. Yeah.
Yes. Well, I think we had more than 325 participants, although we had a CPC just an hour ago. And it was certainly a fantastic lecture. And we look forward to some more from you, because in this period of lockdown where patients are not coming because they don't find transport, we are keeping well informed with a lot of webinars going on. So Sanjay, thank you very much. It's a pleasure. I would have met you in the AN at Toronto, but it got cancelled. So anyway, next AN. Right.
Thanks so much.
Thank you. Thank you very much.